It's really a pleasure and honor to speak here today, and I want to congratulate the European Society of Intensive Care Medicine for organizing a course on physiology. I think that's really fantastic. So, let me start. So these are my disclosures, nothing really related to this talk, I think. And although I was asked to discuss physiology, I want to start with a patient case because it shows that physiology is so important. And this male was in our ICU some time ago, admitted with very severe hypoxemic failure due to a viral pneumonia. Prone position, long-term neuromuscular blockers, and so on and so on. But at some point, he recovered. He was awake, cooperative, basically reading the newspaper. But in his blood gases, pH of 742, CO2 of 41, PF ratio of 160. And this is his ventilator. Right here, 12 of pressure support, 10 of PEEP. And right here you'll see the tidal volumes. And predicted tidal volumes at 6 ml per kilogram would be 450 ml or so. Let me see if I can start a video. So we don't need the sound, I guess. So what you can see here is pretty high tidal volumes, 800 ml, even 1 liter, 1.2 liter, 600 ml, so way beyond what we would want at a 450 ml per liter. And the question is, why is this patient doing this? Because pH is 742, there's no reason for the hypercapnic failure, right? Why is this patient having a high respiratory drive? So to review that, I think we should go a little bit into how respiratory drive is generated. And respiratory drive is generated in the brainstem, more specifically in the respiratory centers right here, originating in the medulla. And if you take a little bit of a closer look, right here, it's a quite complicated picture, but this is the rostral part. The ventral part, you'll see some very important areas. And first this one, the pre-Butzinger complex. The pre-Butzinger complex is an area that contains interneurons that generate the rhythm of inspiration. Another important area is the lateral paraphageal region that generates the rhythm of expiration. So there's different pacemakers for inspiration and for expiration. And there is this post-inspiratory complex, the PICO, that generates more or less the rhythm or activity of the respiratory muscles between inspiration and expiration, the post-inspiratory phase. So that's already rather complex, right? So there's a fourth area that's important. That's the ventral paraphageal region. That's exactly the area where we sense changes in pH in the cerebral spinal fluid. So if pH decreases, this area becomes more active and it stimulates this pre-Butzinger complex. So remember, this pre-Butzinger complex is always active throughout life. But this region for expiration and post-inspiration is only active during higher loading. And there's another interesting thing. Because we know the brain can sense H+, but we're still not sure if the brain can sense CO2. And there's not much evidence out there, although we're still not very sure. But basically, it's sensing of H+ in this area. The respiratory centers for appropriate functioning need feedback from the body. And there's 3 types of feedback. First, the chemical feedback. I touched upon this a little bit. There's cortical feedback and there's a reflex feedback. I'm going to review this into a little bit of detail. So the chemical feedback, H+, and this is a rather complicated picture, but I think it's important. What you see right here is minute ventilation and arterial CO2. And this gray line is the so-called metabolic hyperbola, which describes the effects of changing minute ventilation on arterial CO2. So if minute ventilation decreases, at the same CO2 production, at the same dead space ventilation, arterial CO2 will increase, right? And the position of this metabolic hyperbola is determined by CO2 production and dead space ventilation. When CO2 production increases, the metabolic hyperbola shifts upward. Are you still with me? Okay, sounds good. So there is a second curve here. The second curve is the PaCO2 minute ventilation curve. That dictates that a small increase in arterial CO2, say 1 millimeter of mercury, increases minute ventilation by 2 to 5 liters per minute. So a little bit of increase in CO2 has a very strong effect through H+ on minute ventilation. What happens with a reduction in CO2 is a little bit more complex, as you can see here. As you are sitting here, when you're awake, hopefully, decreasing CO2 decreases minute ventilation, but not up to 0. There's a kind of awakening breathing. So you never stop breathing once you are awake. However, during sleep, a decrease in CO2 will result in a discontinuation of breathing, the so-called apneic threshold. I know it's rather complex, but you wanted to visit a physiology course, so here you are. So, and just if you want to go into a little bit more detail, because it took me some time to understand this as well, this fantastic review just published in the Blue Journal will go into much more detail. Okay, so let's look into a little bit more detail here. So this is minute ventilation, tidal volume, respiratory rate versus end-tidal CO2. As I already told you, if you increase end-tidal CO2, arterial CO2, minute ventilation will increase. So this is healthy subjects. The increase in minute ventilation results from an increase in tidal volume, and initially not respiratory rate. If you start exercising, tidal volume will increase, not the respiratory rate. And this is fundamentally different in our critically ill patients, because these patients have low compliant respiratory system, might have respiratory muscle weakness. So these patients initially will already increase their respiratory rate. But the physiological response is an increase in tidal volume, at least initially. Okay, now things get really complicated. So right here, you've already seen this. Minute ventilation versus arterial CO2, metabolic hyperbola, and at the crossing of the PaCO2, ventilation curve is the equilibrium. That is your actual CO2. So in this healthy subject, a minute ventilation of around 6 liters per minute results in a PaCO2 of 40 millimeters of mercury. However, under certain conditions, a dissociation may develop between respiratory drive and effort. So there's a dissociation between what the brain wants and what the respiratory muscle pump delivers. So what the brain wants, right here, is the brain curve. What the respiratory muscles deliver is your ventilation curve. And you will say, well, I only see one curve. That's right, in a healthy subject. But what happens when you develop a pneumonia? So right here, the first thing you'll see with a pneumonia, that the metabolic hyperbola has shifted upward, right? CO2 production increased, perhaps there is some dead space ventilation, so an elevation of the metabolic hyperbola. If the output of the respiratory centers remains the same, tidal volume will decrease, right? For the same effort, I mean, if the compliance of the respiratory system is low, tidal volume will decrease, minute ventilation decreases, so we're going up to 2. Decreased minute ventilation results in higher CO2, so acidosis. So we're going to move along this line. So what the brain wants right now is a minute ventilation of 45 liters per minute. But respiratory system compliance is low. Perhaps the respiratory muscles are weak. So we only get to this point. So right here, it shows a dissociation between the brain curve and the ventilation curve. The respiratory muscle pump cannot deliver what the brain actually wants. So a shift in the brain curve to the left might occur in the case of metabolic acidosis, hypoxemia, interstitial edema, and so on. A rightward shift might develop in metabolic alkalosis, hyperoxemia, of course sedation. Sedation makes the brain less sensitive to ventilation. And changes in the position of the ventilation curve, an upward shift, can only occur with mechanical ventilation. So for the same effort, there's a higher minute ventilation. And a downward shift of this ventilation curve can occur in any condition that results in respiratory muscle weakness. I know it's complicated, but I think it's very important and it's a very interesting part of the physiology. So to make it simple again, so those who have lost me, come back right here. So pretty simple. Increases in arterial CO2 have a huge response on minute ventilation, somewhere between 2 and 5 liters per minute. And it's important to realize right here, arterial PO2 versus minute ventilation has a much different relationship. You have to become quite severely hypoxemic before PO2 increases minute ventilation, right? So only when PO2 is below 60 millimeters of mercury or 8 kilopascals, it increases your minute ventilation. Okay, so that's the first and most important thing, the chemical feedback to the respiratory centers. But there's also a cortical feedback. Of course, if you want right now, you can start hyperventilating. But as you're just sitting here, you're quite relaxed. The cortex has an inhibitory effect on the respiratory centers. And I'm sure you will all recognize that. Everybody working in the ICU, think about your patients with severe neurotrauma, intracranial bleeding with damage of the cortex. A lot of these patients will have a pH of 750, 755, sometimes even 760. They lose their cortical inhibition on the respiratory centers. And this is the mechanism, actually. And this is associated with a quite bad prognosis. And this is fantastic work by the group of Thomas Similovsky from Paris. So what they actually did is perform EEG of the premotor cortex in healthy subjects and measured inspiratory effort. So right here, so this is the EEG of the premotor cortex, and right here is the airway pressure. So at the start of airway pressure, you don't see any effect, any activity of the premotor cortex. But now, with inspiratory loading, so inspiratory resistance loading, before the start of the effort, so before the airway pressure decreases, there's increased activity of the premotor cortex. So the brain makes you ready to take this deep breath, to take this high effort. And that's very interesting. The German word is Bereitschaftspotential. I don't know why there's a German word for this, because it's a French study, but nevertheless. I mean, it's making yourself ready for a loaded breath. Is this important for us as intensivists? I think so. Because in a subsequent study, they did this while healthy subjects were under non-invasive ventilation. And again, right here, these subjects were in perfect synchrony. Again, EEG of the premotor cortex. And right here, start of the inspiration. You don't see any activity. But now, when they induced asynchrony, difficulties in triggering, trigger delay, inappropriate cycle off, you'll see that before ventilator triggering, there is activity of this premotor cortex. So the same thing, this healthy subject, or perhaps our patient, prepares for this high effort. And what the group of Similovsky actually found is that this activity of the premotor cortex is associated with sensation of dyspnea. And I think that's very interesting. And I'm happy to tell you that the European Society of Intensive Care Medicine, together with the ERS, has now started a task force on this topic, understanding development of dyspnea. I think a lot of you will do a lot of pain scores in the ICU. But raise your hands. How many people ask their patients the sensation of dyspnea? Really? You? Okay, like a structured approach? But I think very few, right? So this is important. So the cortex plays an important role in the regulation of respiratory drive, and patient ventilator asynchrony may increase respiratory drive and generate dyspnea through cortical pathways. Okay, and the third mechanism of feedback is reflex feedback. There are all kinds of mechanosensors in the chest wall, the diaphragm, in the lungs that affect the respiratory centers. And the most well-known, of course, is the Hering-Breuer reflex that increases duration of expiration. I don't want to go into detail right now. You can read it in some more detail in a paper that we're soon going to publish in Critical Care. So you might say it's interesting, it's physiology, but is it important? I still think, yes, it is very important for us as clinicians because low respiratory drive does have adverse events. It is associated with respiratory muscle atrophy, patient ventilator dysynchrony, sleep fragmentation, and on the other hand, a very high drive may result in lung injury, self-inflicted lung injury. I'm sure Professor Gattinoni is going to discuss that in the next talk. But it's also associated to high effort with diaphragm injury, hemodynamic consequences, and very important, sensation of dyspnea. And I just want to highlight that in this slide. Appropriate setting of appropriate titration of respiratory drive is important for the diaphragm. What we now call diaphragm protective ventilation. Try to limit disuse atrophy, but also try to limit a very high effort. So the first conclusion is that regulation of the respiratory drive is complex, and I could have made it much more complex than this, but I really can advise you. I didn't mention that, but there's 2 fantastic papers in Nature reviews about this topic. I really can recommend you to read that tonight if you don't want to go into break. This drive is modulated by all kinds of very complex feedback mechanisms, and an inadequate drive is of clinical importance. And because it's of clinical importance, we have to think about how are we going to assess drive in ICU patients or in physiology in general. Now first, just look at the patient. Just look at your subject. Are there signs of dyspnea, use of accessory inspiratory muscles? But I think the best we can get, because obviously we cannot measure directly the activity of the respiratory centers in the brainstem, but the closest we can get now is electrical activity of the diaphragm. We can measure occlusion pressure. I think all modern ventilators deliver this value, breath by breath. We can assess respiratory muscle output, or perhaps even using ultrasound. And I'm not going into detail right here. I don't have the time, but we're going to discuss that tomorrow in our ventilation workshop, all the different techniques. So that's going to be pretty interesting, I guess. But unfortunately, not the ultrasound. We do not have the time for that tomorrow. But I'm a little bit biased, but I think this is a nice paper published last week in Intensive Care Medicine about ultrasound of the respiratory muscles, which I can recommend you as well. Okay. So now we found our patient has a high respiratory drive. How do we modulate drive? Is there a way that we can modulate this? Well, there is. Perhaps if we are on the ventilator, we can change the level of support. Are there certain drugs we can use? Extracorporeal CO2 regulation? Or, given the cortical influences, can we modulate cortical influences? Well, I saw some interesting data about music therapy, which has become very popular and might reduce dyspnea sensation or respiratory muscle effort, but there's not so much data to discuss. But I'll take you back to this patient, because I saw a couple of people here in the room that had the idea, well, Leo, you're doing a great video here, but look at this, your pressure support is at 12. Why don't you just start reducing your pressure support and your problem is solved? Okay, I'll do so. So right here, we're at pressure support of 5, but still pH was 742, and still tidal volumes were way beyond what we actually wanted, way beyond the 450 ml per kilogram. And that's actually what we evaluated in this study. What is the effect of inspiratory assist on respiratory drive? So these were patients recovering from ARDS on pressure support of 12, tidal volumes of 10 ml per kilogram, and reducing the inspiratory assist by 6 centimeters of water actually decreased tidal volume by only 1 ml per kilogram, not so much. Why is that? Because if you reduce the inspiratory assist delivered by the ventilator, the respiratory drive of the patient will go up. The higher effort by the patient, the reduced inspiratory effort increases respiratory drive, so increases the work of breathing generated by the diaphragm and perhaps can induce muscle injury, while the transpulmonary pressure more or less remains the same. So it's important to realize that it's in a lot of patients, especially in the patients with a high pH, not easy to modulate your respiratory drive, to reduce your respiratory drive. So what about sedatives? I think that's basically your best option. This is a nice study by the group of Paolo Navalesi using propofol and looking at respiratory drive by electrical activity of the diaphragm. No propofol, low dose of propofol, you'll see that the respiratory drive decreases. An even higher dose of propofol, there's a further reduction in respiratory drive, or at least the amplitude of the drive. So that works quite well. But not, he has shown it in another study, but not the opioids. Opioids will not decrease your respiratory drive. It might reduce your respiratory rate, but actually increases the amplitude of the drive. So sometimes you hear people say, well, give some opioids to reduce drive. Usually, it will not work. So this is more experimental way of modulating your respiratory drive. This is a study we did some time ago, using a low dose of neuromuscular blockers. And this is physiology as well, because what we're actually doing here is separating the brain curve from the ventilation curve, right? So these subjects are still breathing by themselves, but for the same output of the respiratory centers, less pressure is developed. So that's what you see here. So we start at 9 ml per kilogram, very low dose of rocuronium, actually allows you to titrate them to 6 ml per kilogram. A lower respiratory drive, not lower respiratory drive. I think the respiratory drive increases, but the mechanical output of the drive is lower. It's not something you should do now, but it's just as an idea. And in patients, not in patients that have hypocapnia and high pH, but if there is a high drive with high CO2, of course, extracorporeal CO2 removal might help to modulate drive. Okay, so if I have 2 more minutes, Mr. Chairman?
Yes, you have.
Yes? Perfect. So there's one other thing I would like to touch upon, and that's the output of the respiratory centers. Output of the respiratory centers, and most of you will think about the respiratory muscles of the diaphragm. And yes, the diaphragm is a fantastic muscle. It's this dome-shaped muscle positioned between the thorax and the abdomen, fulfilling a fantastic task. You know, this is only 1.5 to 2 millimeters in thickness, and it does this fantastic job. But when the load imposed on this muscle increases, when you go out running this afternoon, what first will happen, you're going to recruit your accessory inspiratory muscles. But at some point, you might also recruit your expiratory muscles. And the expiratory muscles, the most important ones from inside to outside, are the transverse abdominis, internal oblique, external oblique. And in some people, rectus abdominis as well. So in which people is the rectus abdominis actually an expiratory muscle?
Chronic bronchitis.
No, not chronic bronchitis.
Asthma.
Not asthma. Look at, I mean, it's interesting. This is my rectus abdominis. If I contract it right now, not much will happen, right? But if your belly is like this, contraction of the rectus abdominis will increase intra-abdominal pressure. So only if you're obese, the rectus abdominis is a real expiratory muscle. So look at this patient. This patient was in our ICU some time ago. We were rounding, and then somebody asked me, why is this patient, why are you using the expiratory muscles? How is that helpful? And that was not so easy to answer that question for me at that time. So we went into the literature, we did a couple of studies on this topic, and a review was published very recently in Intensive Care Medicine. And I think in physiology and pathophysiology, we quite often forget about the expiratory muscles. And we call it like, the expiratory muscles are like the right ventricle of the heart. It has been forgotten for a long time, but very important. So just one or two slides. Why are we recruiting expiratory muscles? Well, I think there are at least 3 reasons to do so. Again, if you go out running this afternoon, you're going to use the respiratory muscles. So if there's an increased loading of the respiratory muscle pump, or with severe weakness of the diaphragm. So if there's a disbalance between the load imposed on the diaphragm and capacity, you'll use your expiratory muscles, or the third option, with pulmonary hyperinflation. So that's the reasons why you do it. So what happens? Well, first, of course, contracting the expiratory muscles results in an increased abdominal pressure during expiration, and this results in a more cranial position of the diaphragm with the next breath. And that makes the diaphragm more efficient in contraction. So that's why you do it if you go out running there. The other thing is, with increasing your abdominal pressure, increases the expiratory driving pressure, so reduces the end expiratory lung volume. So you can use the elastic recoil of your chest wall for the next inspiration. Very smart physiology. And also the increased pleural pressure reduces the expiratory transpulmonary pressure and reduces the lung strain. So the next time you have this patient in your ICU, you see him using the expiratory muscles, make your differential diagnosis. Is the loading too high, so too little of inspiratory assist? Is there a severe weakness of the diaphragm? Is there hyperinflation, perhaps due to too much PEEP? But I think it's important to realize that using the expiratory muscles is not normal for a patient that should be comfortable. So to conclude, Mr. Chairman, I think I have shown you, tried to show you, that respiratory drive is important, and assessment of respiratory drive is important to limit injury to the lung and to the muscles. How are we going to modulate respiratory drive? In some patients by changing the level of assist, and mostly by using sedatives. And finally, look at patients that are using their expiratory muscles. Is this due to inadequate support? Is there hyperinflation? And that's it, basically.
Thank you very much.